What I think about with MCG's role, I really think about our role in creating this common language between the payer and the provider. It is our goal to create content that allows the payer to fully explain why a patient may or may not meet a particular regulation or may or may not need a particular level of service or something like that. And also for the payer to be able to be on that same page and explain their side of it as to why they think that patient may or may not meet that same regulation. And so that's really been our focus, is rolling out some additional content to try to help bridge that gap for under these new regulations. And then really excited to continue to work with our partners in 2024 to smooth that out and find other places where we can build bridges between the understandings. One of the things I always want to caution, especially on the provider side, is that even with this new final rule, Medicare fee-for-service and Medicare Advantage are not going to operate the same. There are still flexibilities that Medicare Advantage has that Medicare fee-for-service does not have. There are also review processes that apply to Medicare fee-for-service that do not apply to Medicare Advantage. And the two-midnight presumption is kind of an example of this. It really precludes fee-for-service from even selecting or reviewing certain claims that Medicare Advantage is still going to be able to select and review. So that little bit of protection you get under that two-midnight presumption rule, you're not going to have that in the MA space. The other big thing that's very different between fee-for-service and Medicare Advantage under this new rule is this idea of MAC discretion. So Medicare Administrative Contractors, or MACs, typically express their discretion in one of two ways, either claim by claim, which nobody can really see until you've submitted a claim, or through a local coverage determination. And so what CMS has said is when there is MAC discretion, if the MAC doesn't actually put their discretion out there in an LCD, then that discretion transfers to the Medicare Advantage plan, and they can create their own internal criteria and express their own discretion. So because of that, what they're putting out might not align perfectly with like a MAC's claim-by-claim discretion, because now you've shifted, again, who's looking at the policy, who's looking at the evidence, and who thinks, where the bar is for medical necessity. So there's still going to be differences between the two programs. There will always be those differences between the two programs. So you just want to make sure that everybody really acknowledges that and make sure they have the right processes in place for the right part of the program that they're going to be billing.